All right, good morning, everybody. Welcome to our fall edition of the Resident Journal Club from the ACCP AmCare PRN. Happy to have two excellent presentations today. The first one, we're going to start with Dr. Yusupov, who's going to be talking to us about CGM and type 1 diabetes, and she is presenting from my home state, actually, of New Jersey. So welcome. We'll let her get started. Thank you for everybody for logging in and learning with us today.
Thank you so much, Elisa, for introduction. Today I will present the journal club on the effect of continuous glucose monitoring on hypoglycemia in older adults with type 1 diabetes. I have no actual or potential conflict of interest in relation to the content of my presentation. The outline includes background of type 1 diabetes, methods, results, conclusion, and critique of the selected article, and impact of study results on the clinical practice. According to CDC National Diabetes Statistic Report 2020, over 34 million adults in the United States, it's approximately 13%, have diabetes. Type 1 accounts for 5 to 10% of all cases. And even though most of the type 1 diabetes diagnosed in childhood, 25% of people can be diagnosed in adulthood, and some of them even at the 9th decade of life. Clinical characteristics of youth onset of type 1 diabetes and diabetes diagnosed in adulthood can differ with regards to the management later in life. Patients with onset in adulthood and detectable C-peptide level have better clinical outcome and lower A1C level with less serious hypoglycemia. Patients with onset in childhood have longer burden of disease, more diabetes-related complications, and higher risk of hypoglycemia and hypoglycemia unawareness. Hypoglycemia is the major barrier in achieving optimal glycemic control, and it's associated with increased mortality and morbidity and reduced quality of life. The major risk factors for severe and recurrent hypoglycemia with type 1 diabetes are hypoglycemia unawareness and poor awareness. And it's the big concern for elderly people, especially because of the high risk of falls, cognitive impairment, and cardiovascular disease. Continuous glucose monitoring, which I'm going to abbreviate as CGM in my presentation, can be a very helpful tool for this vulnerable population. The use of CGM has grown in the past couple of years. It allows patients to evaluate their individual's response to the therapy and to providers to help assess patients' hypoglycemia, hyperglycemia, or glycemic variability by generating ambulatory glucose profile report, which includes major 3 measurements: the percentage of time spent in the target range of glucose, below target range, and above target range. And because of the elevated risk of hypoglycemia in elderly patients, guidelines recommend to lower percentage of time spent within target range from more than 70% to more than 50%, and reduce time below the target range to less than 1% at the level of less than 70 milligrams per deciliter. Several randomized controlled trials have demonstrated the efficacy of CGM in the elderly patients. However, none of them included substantial number of adults. For older adults, Diamond trial included elderly patients with both type 1 and type 2 diabetes. However, only 20 patients with type 1 diabetes were included in CGM group. And even though the significance of CGM was shown have benefit in control of A1C level and variability, the rate of hypoglycemia was not reduced, and therefore we cannot apply the results of these trials to the elderly patients with type 1 diabetes with high risk of hypoglycemia and its complications. In June 2020, the Wisdom Study Group conducted the trial to evaluate the continuous glucose monitoring on hypoglycemia in elderly patients with type 1 diabetes. It was a randomized clinical trial in 22 endocrinology practice in the United States between October 2017 and June 2018. The primary goal was to assess the efficacy of CGM in reducing hypoglycemia compared with the standard blood glucose monitoring, which I'm going to abbreviate standard BGM in my presentation. Patients were randomized to use either CGM with the regular study glucose meter as needed, or just the study glucose meter to check blood glucose at least 4 times a day. Both groups had clinical visits at 4, 8, 16, and 26 weeks following randomization. Patients were included in the trial with type 1 diabetes of 60 years of old or older, with A1C level less than 10, BMI less than 30, and the patients who were using either the insulin pump or multiple daily insulin injections, and those who didn't use the real-time CGM in the 3 months prior to enrollment. Patients were excluded if they used unblinded CGM outside of the research study, the ones with the known adhesive allergy or skin reaction, extreme visual or hearing impairment, clinical diagnosis of dementia, or renal failure with eGFR less than 30. Primary endpoints of the trial was the percentage of time spent with the glucose value less than 70 during the follow-up, using the data pulled from the approximately 7 days prior to the week 8, 16, and 26 visits. Secondary outcomes include hypoglycemia and hyperglycemia outcomes, timed with glucose values between 70 to 180 milligrams per deciliter, glycemic variability, change in A1C level, and also quality of life using the PROMIS Global Health short form, which is the assessment tool that allows measure symptoms, functioning, and healthcare related quality of life, and also National Institute of Health Toolbox, which is the comprehensive set of neurobehavioral measurements that quickly assess cognitive, emotional, sensory, and motor function of patients. Secondary outcomes also included hypoglycemia awareness, hypoglycemia fear, and diabetes distress. For statistical analysis, a sample of 200 participants was determined in order to achieve 90% power to detect the reduction in percentage of time spent with the glucose level less than 70 for overall population, and 80% power for subgroup analysis by insulin delivery method. Primary analysis and safety analysis were based on the intention to treat population, which include all patients who were randomized initially. And per protocol analysis would be performed only if at least 10% of participants would be excluded by this criteria. Total of 219 patients were assessed for eligibility. 16 patients were excluded, 7 of which didn't meet inclusion criteria, 8 declined to participate, and 1 patient was excluded because, for having at least one severe hypoglycemia event within 6 months, and spend more than 10% with glucose level less than 54. So total of 203 patients were randomized, with 103 patients to use CGM and 100 patients to use standard BGM. One patient in CGM group and 6 patients in standard BGM group were missing follow-up data, but it was included using the direct likelihood, and the data from the baseline of these patients were also included in the analysis. Baseline characteristics were similar between two groups. Most of the patients were less than 70 years old with prolonged duration of diabetes of between 35 to 39 years. The mean A1C level was approximately 7.5, and more than 90% of patients were white with high socioeconomic status. The CGM group had 2 times more patients with at least one severe hypoglycemia event within 12 months comparing to the standard BGM group. In the primary analysis, median percentage of time spent with the glucose level less than 70 reduced from 5.1% to 2.7% in baseline in CGM group, and stayed relatively unchanged from 4.7 to 4.9 in standard BGM group, with adjustment difference of 1.9% and p-value of less than 0.001%. Results were similar for other CGM hypoglycemia metrics, and in addition to the reduction in hypoglycemia with CGM, significant treatment group difference were observed in hyperglycemia, mean glucose concentration, glycemic variability, and change in A1C. A significant benefit of CGM in reduction of hypoglycemia were observed for any of the participants at the beginning of the study and stayed consistent over 6 months. It's represented on the left graph with the time spent with glucose level less than 70 on the y-axis and study visit time frame on the x-axis. On the right graph, you may see that also the evidence of CGM efficacy in reduction of hypoglycemia during the daytime and before bedtime. The thin lines represent 25th and 75th percentile, and thicker lines median. So you may see that patients in CGM group had spent less time with glucose level less than 70 throughout the whole day. No statistical significant treatment group difference were observed for any patient-reported outcomes and cognitive assessment, including hypoglycemia awareness, hypoglycemia fear, the quality of life based on PROMIS Global Health short form, and National Institute of Health toolbox. In terms of safety, 1% in CGM group and 1 patient in CGM group and 10 patients in standard BGM group developed severe hypoglycemia. The only 1 patient who developed hypoglycemia in CGM group was on insulin pump. There were no statistically significant treatment group difference in fractures, falls, hospitalization, and emergency department visits. So authors concluded that there was a small but statistically significant improvement in hypoglycemia over 6 months with use of CGM as compared to standard blood glucose monitoring. And because authors didn't achieve the recommended less than 1% target for time with glucose level less than 70 for elderly patients. Further research of longer duration is needed to determine the clinical benefit. The strength of the study included high participant retention rate with a high degree of CGM device use in CGM group. And even though it was impossible to mask the assigned intervention, the amount of contact with participants was similar between groups. Authors also was able to achieve predetermined 90% power for primary outcome, and they stratified the study results based on the insulin delivery method. And another thing, they also included the quality of life outcomes, which is very important for elderly patients. The limitation included limited inclusion, limited diversity of population. Most of the patients were white with high socioeconomic status. Most of the patients were relatively young and with relatively good A1C level. And also the high number of patients with previous episodes of hypoglycemia in one group could also intensify the primary outcomes. Of course, short intervention period of 6 months didn't let us to assess the clinical benefit of the results. And we currently have more advanced CGM sensor that could be potentially more efficient in elderly patients. The comparison of Wisdom Group trial with Diamond trial help us to visualize the major strengths and limitations of the trial. Wisdom Group trial had 10 more patients, elderly patients with type 1 diabetes. However, Diamond trial had more diverse patient population and much higher baseline A1C level. And of course, Wisdom Group trial used more advanced CGM device because it was conducted 3 years after the Diamond trial. The implication of CGM in clinical practice is quite limited now because of the lack of training and support for primary care. However, the hypoglycemia and high risk of hypoglycemia in elderly patients can, it's very important and can go unnoticed with traditional glucose monitoring, and especially those who were with the longer burden of disease and or cognitive dysfunction. CGM can provide dynamic glucose information and can anticipate periods of hypo and hyperglycemia. And we as a pharmacist have an important role in providing education, interpreting the results, and recommend insulin adjustment accordingly. The role of pharmacist in CGM is enormous. We can educate primary care providers and patients. We can help to select patient the most appropriate device based on the accuracy, data sharing, convenience, and cost. We can assist patients with learning how to insert the sensor that can be very challenging, especially for elderly patients. And of course, we can optimize adherence by providing patient education and how to utilize the AGP report and interpret the data from this report to implement change in treatment and to promote change in patients' life decisions. So the take-home points that I would like you to take from my presentation, it's once again emphasize the high risk of hypoglycemia in elderly patients that may contribute to dementia, risk of falls, glycemic variability, and mortality. CGM may reduce the hypoglycemia events, which has the utility in healthcare by providing mortality, morbidity, and economic benefits. And in combination with adequate education and training, CGM can help patients to achieve their glucose targets. And for pharmacists, it's a great opportunity to be involved and to further contribute to the management of type 1 diabetes. This is all I have. Thank you so much. And with that, I'll take any questions. Anybody can hear me?
Yeah, excellent presentation. I had a quick question. In your practice site, have you had many barriers in getting patients with type 1 diabetes actually, I don't know, like insurance barriers or cost barriers to actually getting them on CGM?
Yes, in our hospital, we have ambulatory clinic for low-income patients, and of course, the price and coverage is the big issue for this patient population. And unfortunately, I didn't take care of elderly patients with type 1 diabetes in our clinic yet, and I'm not really sure if it will be covered somehow, like through the 340B maybe. Yes. Any other questions?
Okay, I'll take that as no questions, and we'll let Dr. Lankford get his slides pulled up, and we'll move on to the next presentation.
Can you see my slides, Alyssa?
Yeah, I could see them there. We could see the presenter view.
Okay, that's what I was wondering. Let me try to fix that real quick.
Okay. All right, that looks great.
Okay, perfect. Sorry about that.
Oh, that's okay. So our second presenter today is Dr. Lankford. He is coming from Reno. He's going to talk to us about one of our newer agents, Inclisiran. So I'll let him have the floor, and then we'll have the opportunity to ask any burning questions at the end before we sign off for the day.
All right, yeah, so as Dr. Nathan said, my name is Cory. Today we're going to be talking about Inclisiran, as she said, and I am the current PGY2 ambulatory care pharmacy resident here at Renown Health in Reno, Nevada. So before we get started, I would like to thank my mentors for taking the time to help me put this presentation together. So thank you, Jason, Laura, and Eliza. As far as disclosures go, we have nothing to disclose in regard to the content of the presentation today. So the article that we're going to be discussing was published in the New England Journal of Medicine earlier this year. And it's kind of unique because they actually published 2 trials in one manuscript. And so it was titled 2 phase 3 trials of Inclisiran in patients with elevated LDL cholesterol. A little bit of background before we dive into the trial. So we know that when patients have elevated LDL levels and when they are exposed to these levels for prolonged periods of time, that this increases their risk of developing ASCVD or atherosclerotic cardiovascular disease. So this is things like MI, stroke, unstable angina, etc. Current guidelines actually recommend that PCSK9 inhibitors are used last line for most patients. Typically, patients should be tried on statin therapy and then other lipid-lowering therapies such as ezetimibe prior to using PCSK9 agents. The PCSK9 agents that are currently available today on the market are Repatha and Praluent. These medications can be administered by patients in the comfort of their own homes, and they are administered every 2 to 4 weeks. They're very effective medications, and they lower LDL levels by approximately 50 to 60% with a relatively minimal side effect profile. However, a significant barrier to the treatment or use of these agents has been cost. And then also, before we dive into the Orion 10 and Orion 11 trials, I did want to touch on the Orion 9 trial that was published around the same time. This trial looked at the use of Inclisiran in a large cohort of adult patients with heterozygous familial hypercholesterolemia. So for those of you that are unaware, heterozygous familial hypercholesterolemia, or FH, is where patients have a genetic mutation that predisposes them to elevated LDL cholesterol levels. Patients can have one mutation where they're considered heterozygous, or they can have 2 mutations where they're considered homozygous, and the patients with the 2 mutations are at risk for even higher LDL levels. So Orion 9 looks specifically at heterozygous FH patients, and what they found was that Inclisiran treatment was associated with an infrequent dosing regimen, as well as an acceptable safety profile. They found that LDL levels were also decreased by approximately 40% when patients were put on Inclisiran. So Inclisiran is obviously a cholesterol lowering therapy. It's not currently approved by the FDA as of yet, but we'll get more into that later. It is a small interfering RNA that inhibits translation of the protein PCSK9. So this is different than the current agents on the market. It doesn't inhibit PCSK9 after it's produced. It actually reduces the expression of PCSK9 in hepatocytes. So what this effectively does is increases LDL receptor recycling and expression. And so the dose of Inclisiran is 300 milligrams, and it's a subcutaneous injection. And the Orion 1 trial established that this medication could actually be administered every 6 months after the initial first 2 doses. So you could almost kind of think of these as a loading dose, if you will. And these loading doses took place on days 1 and 90. Inclisiran is meant to be administered by a healthcare professional, and I have my own thoughts on this. I think that being administered by a healthcare professional every 6 months allows for a follow-up period. And I know that in our clinic, that we typically, once we put patients on PCSK9 inhibitors, and once they're established on these therapies, we typically see them every 6 months. So we'll dive into the two trials, or the meat of the presentation today. The two trials had the same objective. So they wanted to assess the safety, efficacy, and adverse event profile of inclisiran over a period of 18 months in patients that were at high risk for cardiovascular disease. So this was defined as patients with elevated LDL cholesterol levels despite receiving maximally tolerated statin therapy, with or without additional lipid-lowering therapy. So both trials were randomized, double-blind, placebo-controlled, parallel group phase 3 trials. Orion 10 took place in the United States, and Orion 11 took place in Europe and South Africa. In regard to inclusion criteria, they were slightly different. So Orion 10 only included patients that had established ASCVD, and it had to be patients with ASCVD that weren't at their LDL goal. So their LDL had to be greater than or equal to 70 milligrams per deciliter. While Orion 11 had the same inclusion criteria, they also included an ASCVD risk equivalent population. So they define this as patients with type 2 diabetes, heterozygous FH, and patients at a significant ASCVD risk score of greater than or equal to 20%. If patients were included in the Orion 11 trial with the ASCVD risk equivalent, they had to have an LDL level that was, again, not at goal, so greater than or equal to 100 milligrams per deciliter. And both trials had similar exclusion criteria in that patients had to be on background lipid-lowering, stable doses of background lipid-lowering therapies the 30 days prior to screening. And then they also couldn't have been on monoclonal antibodies directed toward PCSK9 the 90 days before screening as well. So in regard to methods, inclisiran was compared to placebo, and so they administered inclisiran at a dose of 284 milligrams, which is equivalent to inclisiran sodium 300 milligrams. And both of these were administered as 1.5 ml subcutaneous injections. The injections occurred on days 1 and then at 3 months, so day 90, and then after day 90, they occurred every 6 months thereafter. Follow-up and laboratory assessments occurred on day 30, and then they were effectively every 60 days after the injection. Primary endpoints that were included were the percentage change in LDL level from baseline to day 510, and then the mean change in LDL level from baseline after day 90 and up to day 540. So what this means is essentially after that loading dose period, the mean change in LDL level after day 90. So once patients started on that 6-month dosing interval. Secondary endpoints included absolute change in LDL level from baseline to day 510. And then again, the time adjusted absolute change in LDL cholesterol level from baseline after day 90 and up to day 540. They also investigated the percent change from baseline to day 510 in levels of PCSK9, total cholesterol, apolipoprotein B, and non-HDL cholesterol. So the baseline characteristics, both studies had nearly 1,600 patients, and the groups were split fairly evenly in regard to patients that were put on inclisiran versus placebo. And there's just a few things that I wanted to point out in regard to baseline characteristics. So the majority of the participants were Caucasian, and then a very, very small percentage of the patients actually had heterozygous FH in this study. However, as I stated before, the Orion 9 trial investigated this population specifically. And then in regard to high intensity statin use, there was in the Orion 10 trial, approximately 70% of the patients were on high intensity statin, and Orion 11, approximately 80%. And then as I stated, Orion 10 only included patients with ASCVD, but Orion 11 had that ASCVD risk equivalent. So I just wanted to point out the amount of patients with established ASCVD in Orion 11 was about 87%, where they included about 12% of the patients with ASCVD risk equivalent. And then I also just wanted to note that both trials were similar in regard to patient age. It was about 65. And in regard to sex, there were approximately 70% men in both trials. Moving on to results. So first we'll discuss the percent change in LDL cholesterol. And just to orient you to the graphs, the top panel is Orion 10 and the bottom panel is Orion 11. And on the x-axis, we have time in days, and on the y-axis, we have percent change from baseline in LDL cholesterol. So first we'll discuss Orion 10. We can see that from baseline to day 510, Inclisiran decreased LDL cholesterol by approximately 51.3%. And compared with placebo, there was a between group difference of about 52%, and it was statistically significant. Looking to Orion 11, so the bottom graph, we can see that Inclisiran decreased LDL cholesterol levels by approximately 45.8%, and when compared to placebo, there was a between group difference of approximately 50% that was again statistically significant. Looking to the absolute change in LDL cholesterol, again, we have on the top panel Orion 10 and on the bottom panel Orion 11. And then the x-axis is time in days and the y-axis is LDL cholesterol level. So Orion 10 from baseline to day 510, we can see that Inclisiran decreased cholesterol levels or LDL cholesterol levels by 56 milligrams per deciliter. And then when compared to placebo, there is a between group difference of 54 milligrams per deciliter. And this was again statistically significant. And then looking to the bottom graph for Orion 11, we can see that Inclisiran decreased LDL cholesterol levels by 50 milligrams per deciliter. And when compared with placebo, there was a between group difference of approximately 52 milligrams per deciliter that was, again, statistically significant. In regard to adverse events that occurred, the majority of the adverse events that were reported were of mild to moderate severity, and there was no statistically significant difference between the adverse events that occurred aside from injection site reactions. So these were the only reactions that occurred more, and it was statistical significance with Inclisiran compared to placebo. However, the majority of these reactions were, again, of mild to moderate severity, with none being severe or persistent. Another interesting side effect that was noted in the studies was the formation of anti-drug antibodies. And this was measured in plasma with quote unquote highly sensitive screening methods. And this was supplemented with confirmatory assays. And this was to minimize the risk of false negative results. We can see that the presence of these antibodies in post-treatment samples was of low titer. And the authors noted that it was transient and it was not associated with any change in pharmacologic or clinical variables. The author concluded that sustained reductions in LDL cholesterol levels were achievable with an infrequent dosing schedule of every 6 months with Inclisiran. And they also concluded that Inclisiran reduced LDL cholesterol levels by approximately 50% in these studies. And then, as we just spoke about, injection site reactions were the most frequent reaction, and this was statistically significant when compared with Inclisiran versus placebo. My conclusions are that this is a novel PCSK9 acting agent with a unique mechanism of action that differentiates it from currently available therapies. And its effectiveness does appear to be fairly comparable with currently available PCSK9 agents. However, it does have a more favorable dosing interval of every 6 months. However, at this time, we do need more long-term safety and outcomes data. Some limitations of this study, so they didn't have a sufficient total number of cardiovascular events observed to draw any meaningful conclusions about the potential benefits of Inclisiran on cardiovascular outcomes. We'll talk about that a little bit more on the next slide. And then they also had fairly limited generalizability. So the majority of both cohorts were white males. And then they had a low number of heterozygous FH patients enrolled. However, Orion 9 did address this population specifically. And then something that was fairly interesting to me was that 60 to 80% of the patients enrolled were on high intensity statin therapy. So you would think that the patients that have these elevated LDL levels would be on higher doses of statin therapy. However, you could also think that this models more real life in that the majority of the time when patients are put on these injectable PCSK9 agents, This is because they cannot take a statin. So next steps. Orion 4 is currently recruiting, and it's assessing the impact of inclisiran on cardiovascular outcomes, and they're aiming for approximately 15,000 ASCVD subjects. It's estimated to be completed in 2024. And then Orion 5 is actually going to be completed in next year, June of next year, and it's investigating the safety, tolerability, and efficacy in the homozygous FH population. The manufacturer Novartis is also planning a primary prevention trial to take place in the United Kingdom, and this is specifically just with inclisiran in primary prevention, so it'll be interesting to see what they find there. In regard to projected approval date, the manufacturer reports that it could be as soon as early next year. However, they're confident that it'll happen before December of 2024. They haven't definitively disclosed the cost of the medication yet. However, the manufacturer has claimed that it will be significantly more affordable versus currently available PCSK9 agents. The authors of these studies have actually commented as well that this medication, as I stated, will be administered by healthcare providers and most likely in the clinic setting and potentially community pharmacies. So this does represent significant pharmacist opportunity to be more involved in care for patients with elevated LDL levels. Impact on clinical practice. So looking at the primary prevention population, so Orion 9 and Orion 11 did include some. So Orion 9 looked at, as I stated, heterozygous patients, so not necessarily patients with established ASCVD. And then Orion 11, while they only had about 12 to 13% of their patients with that ASCVD risk equivalent, they did not have established ASCVD. So there does seem to be some evidence pointing that inclisiran could have a benefit in patients with primary prevention where their LDL is not at goal, despite maximizing other lipid-lowering therapy. However, the cost versus benefit has yet to be eluded at this time. That trial in the UK will hopefully shed some more light on this. In regard to secondary prevention, Orion 10 and Orion 11 both showed that patients with established ASCVD with LDL levels not at goal, despite maximally tolerated lipid-lowering therapy, that this medication did lower their LDL levels. So there is some promise there. Other considerations, so patients with adherence challenges. I know that in our clinic, sometimes as I stated, we follow up with patients once they're on PCSK9 therapy approximately every 6 months or so. Sometimes these patients will run out of refills or they haven't been on this medication, for the last month or so. And so the potential of every 6-month dosing where we are able to administer the medication, we know that the patients are getting this therapy, that is a significant benefit. So they're, as I stated, patients with adherence challenges, lots of opportunity there. And then patients with needle phobia, so rather than injecting every 2 to 4 weeks, they would just have to inject at the, that loading period and then every 6 months thereafter. And then inclisiran was studied just in addition to statin therapy. However, there is the potential of monotherapy. So it could be an alternative for patients, as I stated before, with an inability to take a statin. And then also that Orion 5 trial, I'm excited to see what the outcomes are in the homozygous FH patient population. And with that, I'll take any questions that you may have.
Great job, Cory. I just had a question kind of about what your thoughts are in terms of, provider pickup of using this agent, since the PCSK9 inhibitors have, been on the market for a few years and people are, getting used to using them in a variety, the spectrum of cardiovascular disease states. So with it being kind of similar but kind of different, what do you anticipate, challenges or wins to kind of take to our providers about this medication?
I think honestly that the data, because we don't have any data on outcomes specifically yet, as far as how much does this really decrease risk? It does, obviously, you know, as these studies have shown, lower cholesterol levels. So I think showing that, you know, it does lower cholesterol levels by approximately that 50% or so, which is comparable to the currently available therapies. And then the option of just administering every 6 months versus having patients have to administer it at home. I think that those are definitely selling points. However, we still kind of need that the data on the outcomes in regard to cardiovascular events to really help sell this. I know that in our clinic, as you know, the newer agent bempedoic acid, our providers were very eager to start using that. They were excited about it. So I anticipate that response for us here at our clinic. But yeah, there could be some hesitancy there for sure. But I think the further studies will kind of help to persuade them.
Yeah, it's always nice to have something like new and shiny to use.
Right,
So,
yeah.
Any other questions from any other people logged in? All right, I guess I'll take that as a no. Excellent job to both residents. Thanks for teaching us something new. Thank you to Kevin for setting up everything on Zoom, and thank you to all the mentors who've helped the residents throughout this process. Excellent job, and we'll get this posted to the PRN website as soon as we can. Thank you, guys.
Thanks.
Thank you so much.